Welcome to Pathways to Equity, a podcast that presents ways to make health systems around the world more equitable for everyone. I'm Nathan Blanchette, your host. I'm also the project director for the Health System Strengthening Accelerator project. The Accelerator is a 6-year initiative working with 17 countries in Africa and Asia. And the goal was to build more resilient, high-performing health systems that benefit vulnerable populations. It supports locally led development with a focus on equity. The Accelerator is funded by the U.S. Agency for International Development, or USAID, with co-financing from the Bill and Melinda Gates Foundation. Results for Development, or R4D, leads implementation of the Accelerator in partnership with ICF and the Health Strategy and Delivery Foundation, in addition to regional, national, and local partners where we work. One key challenge faced by health systems globally is how to improve health equity, both in terms of the processes that health systems use, as well as the outcomes for people who are poor, marginalized, or otherwise underserved and underrepresented. But what makes healthcare equitable? One aspect is everyone having access to the care they need. That is a lofty goal anywhere. In many countries, poor patients, especially those who live in rural areas, may have trouble accessing health services that have the resources they need. Travel distance and user fees are common obstacles to obtaining high-quality care. Socially excluded populations, such as people who face stigma for being HIV positive or for having disabilities, face additional and often invisible barriers. Not to mention that community-level stakeholders, people from civil society organizations, women, youth, and vulnerable populations, may not have a seat at the table in terms of making decisions about health policies and programs that affect their lives. In this series, we're going to explore some of the obstacles to health equity. And I interviewed people from 4 countries, Benin, Togo, Ghana, and Guinea, about some of the solutions they found and progress they've made. All of the interviews happen to focus on countries in West Africa, but I want to say the examples talked about common issues facing health systems globally. For example, households with less money, who live in rural areas, or who have less education typically have much worse health outcomes. In Guinea, for example, child mortality for children under 5 years of age is a startling 3 times higher for children from the poorest households compared to the richest. This pattern persists with varying degrees of magnitude across all 4 of these countries and many others. In the rest of this episode, we're going to hear from 2 people. The first, USAID's Jody Charles, about what it takes to do equity work well.
We're really getting better at not only listening to people that we should be listening to, but giving ourselves a little bit of a check. We need to check ourselves a lot more, and we're doing a better job than we used to.
And later, we'll hear from a doctor and a leader of a local research organization in Benin, who advocates for making the cost of healthcare more accessible for patients in his country.
Based on what I have observed, asking a poor woman at the end of 9 months of pregnancy to pay before delivering in a safe condition is a very violent policy.
Before we really dig into examples of work that countries are doing to improve health equity, I wanted to start this series from a global perspective. The U.S. Agency for International Development, or USAID, is the main funder of our Accelerator project. Since we started the Accelerator 6 years ago, USAID has been a trusted guide as we've worked in countries with different healthcare systems and context-specific challenges. Improving health equity requires multiple approaches and deliberate attention to make sure that health policies and programs benefit those who need them. It takes a lot of work to change systems and to go beyond surface-level problems. So it's important to approach health equity with thoughtful care and humility. And that's where I wanted to start my conversation with Jody Charles. She's the Senior Health Systems Advisor for the Office of Health Systems at USAID and has a lot of experience with this work.
I've been working in health system strengthening for about 20 years.
Jody helped us establish the right strategy for working with partner countries. The goal of the Accelerator was to improve the health system from top to bottom, to ultimately help country leaders adapt their health systems to better address the needs of vulnerable populations. And we wanted to co-create solutions with all stakeholders of the health system. One question I have is that when you look at these kinds of programs, whether it's infectious disease programs or in the space of universal health coverage, there's programs that are trying to extend health insurance, for example, to the poor. You've been in this space and seen equity in different dimensions for a long time now. Do you feel like we're moving the needle? Are we doing enough? Or is there more out there that we need to do?
The answer is we are doing quite a lot. And increasingly, we're doing more on health equity and being much more sophisticated and deliberate in our approach. But we can definitely be doing a lot more. In my mind, and this is completely personal, but I had broken it up into 4 categories. The first one being we need to challenge our assumptions, right? We challenge our assumptions about improving equity. And if we say we're doing it, are we really doing it? The second thing is understanding that it's not a zero-sum game. The third thing is that this is not optional. None of this is optional. We need to think about this as being an absolute requirement and approach it from that perspective. These are not extras, right? And then the fourth thing was embracing complexity. We really need to understand the importance of complexity and complex adaptive systems when we're talking about equity. It does not mean that everything is going to be complicated, but it does mean that we have to be willing to look at things that are maybe a bit more distal, that are maybe more of a contribution to an outcome, that look at these intermediate outcomes. Those are 4 buckets that I had come up with, sort of think of these things. One of the things that has been encouraging looking at the evolution over 20 years is that we're really getting better at not only listening to people that we should be listening to, but giving ourselves a little bit of a check. We need to check ourselves a lot more, and we're doing a better job than we used to.
I think there sometimes is potentially still a tendency to think first and foremost about income and thinking about, oh, a program should be pro-poor. But maybe you can say a little bit more about this. I think from the approaches and examples you were just listing off, you clearly have in mind dimensions that go way beyond just the income and wealth.
I think we need to be challenging our assumptions on things like effectiveness and efficiency. When we say that we're improving equity, is that really true? We need to be careful not to make the assumption that because we have included something in a benefits package or because we have offered those benefits to a particular group of people who are underserved, we shouldn't assume that means that they're actually utilizing the services. It's incredibly critical that we track enrollment. But there are other dimensions we need to look at if we're talking about whether or not people are actually utilizing those services. When we look at equity, one of the first things that comes to mind for people is socioeconomic status. And are we reaching the poorest of the poor? And that has been and continues to be absolutely critical. But there are usually additional dimensions that we can look at. People who are marginalized are often poor, but it's helpful to look at a more complex set of indicators or statistics on a population to see what else might be driving those inequities. We do look at things like gender, geographic location, as well as income. It's also worth looking at, depending on data is available, things like, are people with disabilities able to access services? What about groups with different religious beliefs, different ethnicity, different language? It doesn't mean that you need to program against every single specific indicator, but it's important to take those into account when you're deciding what are we going to program against, what are we going to fund, who is missing. And it's important to sort of cross-reference a lot of those different dimensions to make sure that you really are maximizing the benefit to the maximum number of people. And from a systems perspective, that means focusing on the underlying system issues that impede equity, looking at things like context, taking a political economy approach, a geopolitical approach, looking at all those different factors that are going to tell us who do we need to actually be reaching.
So how do we know if we're including the right people? Something Jody mentioned was that the best equity work brings a variety of healthcare worker voices to the table, and she shared a story of why and how this works. A few years ago, she was in Mali for a workshop planning services for maternal health.
The planners made the decision that they were going to bring in a very large group of midwives from these rural communities. And they decided they needed to have translation. They had very specific simultaneous translation for French, English, and Bambara. And something as simple as that can have such a tremendous impact. We walk into the workshop, and on the first day, people walk in, suits and ties and attachés, and they walk up to the front, and they put their coats on their seats, and everybody claims their seats. And it's about what you would expect. You have all of these global experts sitting in the front tables, and then you have a lot of the country people sitting in the middle table, and then way in the back, really backed by the translators, you had this 2 tables of midwives. And on the first day, the workshop went probably pretty much as you would expect. There are people at the front who were talking, a lot of presentations, eyes focused forward. And that was the dynamic in the room when we started. But one of the things that we saw, which was absolutely fantastic, was that over time, we saw the midwives get more and more engaged. And what was fascinating was to watch the sort of center of gravity, if you will, of that room over the course of that week switched from the front of the room all the way to the back. Day 2, it really shifted to the point where the back of the room, the midwives had all pushed the tables together. They were all sitting around, and you saw all these people standing in the back with their notepads, sleeves rolled up, and listening really attentively to everything that these women were saying. By the end of that workshop, they weren't raising their hands and trying to fit in their voice in between pauses. They were taking a very assertive role and were very much leading the discussion by the end of that. And that was fantastic to see. It was something as simple as having a set of facilitators who understood the assignment, so to speak, and making sure that you had good translation and that it wasn't an afterthought.
Wow, Jody, what a fantastic story. I love it.
I love that. Best workshop I ever went to.
It's a very powerful thing to see. And, I think it also represents something we have talked about before, is that equity, yes, it is about the ultimate outcomes. Yes, we have to pay attention to whether we're seeing higher rates of child mortality among the poor versus the wealthier quintiles of society. But you have to think about it a lot earlier than that.
Yeah.
I think what you're saying here is that you've got to think about it from that very first step of designing a new program or, setting a new policy. And here you had a recognition that no, there's a group, in this case, midwives, who know things that we don't know, who know populations that we don't necessarily hear from. And they've got to be given that space to voice their wisdom. A significant lesson learned here is that improving equity is not a one and done achievement. Addressing equity needs to happen in an ongoing way across multiple phases of work, and it's crucial to include less powerful voices from the beginning.
Looking across the 20 years, I have seen a lot of progress. I've seen us go from being the flown-in technical experts who write the documents and provide the solutions to that shifting and being in a responsive and receptive position to say, tell me what you need me to do to make sure that we get the resources we need to the right place based on your strategy. It's not solely about shifting the resources to local organizations. It's also about shifting the leadership, as you said, shifting our own roles to being responsive to that leadership, and how do we provide technical support under the leadership of those local organizations. I think it's a fantastic dynamic to see. I love being a part of it, and I want to see more of it, frankly.
I couldn't agree more with Jody. After working with our partner countries for 6 years, the accelerator was able to make progress because we worked so closely and relied on the knowledge of local health workers and leaders. And that's what the rest of this podcast episode and series will focus on. I interviewed doctors, researchers, and other health system leaders focused on improving equity. They share some of their lessons learned, as well as share what progress they made to make their country's health systems more equitable. Jody gave us a great overview of some of the health equity issues that exist globally. But in the rest of this series, I talked to people in countries working to solve these issues. The first equity challenge I want to talk about is the cost of care. And to illustrate this problem, we're going to speak with a health system leader from Benin. Benin is home to 13 million people, and healthcare affordability has been a major issue. For example, the child mortality rate is almost double for children from the poorest households compared with children from the wealthiest households. The government in Benin is trying to address these disparities by creating a national health insurance program that facilitates access to more affordable, accessible, high-quality healthcare. I spoke with Dr. Jean-Paul Dossou of the Center for Research in Human Reproduction and Demography, or CERHUD. CERHUD is a leading organization working on health systems research, policy, and programming in Benin and across the West African region. I wanted to talk to Dr. Dossou because he has firsthand experience with the complexities of getting equity right in health policies.
When I was doing my medical studies, we write in the medical files of a patient that, look, this patient died because he could not afford care. He could not afford paying prescriptions. He could not afford a surgical procedure. I have been trained in this kind of context.
In Benin, many patients have to pay user fees to access care. These are fees that patients are expected to pay at the time that they get care. And like Dr. Dossou said, these fees can be life-threatening to some patients. He saw how user fees impacted people in hospital settings, but he's also seen how user fees in other areas like education can have a lasting impact on someone's life.
My dad was a teacher. He used to work in villages as a kid of a teacher. I do hate from that moment certain privilege. For instance, I do not have to pay school fees, and that can make a big difference. My classmates have to walk 5 kilometers, 6 kilometers before they come to office every day. They can be forced to stop coming to school because they cannot pay school fees. And what happened is today I am a medical doctor, but I feel like in my class, most of them may have also possibility to become medical doctors too, or to embrace other maybe high-level career. But they failed to do so, not because they are not brilliant or they are not competent, but simply because structures around us at that moment created conditions not to give them the chance to express their talents and to express their capacities. The system around us can be constructed in the way to reinforce our vulnerabilities.
So Dr. Dossou grew up observing these inequities, but he didn't use that word inequity when he was a child in school. It really wasn't until he was getting his master's in public health and studying how different health systems can work.
And that opened my eyes widely on how health system related aspects can build structures and constraint around people.
As Dr. Dossou's career progressed, he began to see inequities throughout Benin's health system, like the public university hospital where he was trained. One of the realities in that hospital was that civil servants working for the government have a type of insurance that subsidizes user fees.
But 85% of the population have to pay for everything. You have rich people like civil servants, they already do have kind of salary, but when they come to the hospital, they can receive also exemptions. anybody else, the merchants, the farmers, all those people that are not civil servants have to pay everything. And look, most of them fail to join hospital. Most of them die even before joining hospital. And those who join hospital, some of them afford to pay for the care. Others never do, or they do only after selling many of their goods. They sell their cars if they have one, or they sell their motorbike, they sell their bike, or they have to take loans, or even sometimes they cannot just access care and they die.
I wonder if we might stay on that topic of cost, which are an obvious barrier for healthcare for the poor. Can you give us a little background on how the thinking about those user fees has evolved in recent years in Benin?
Benin belonged to the East Bloc during the Cold War period. So Benin was a communist country from the 70s to 1990. So in that period, when the Benin belonged to the communist bloc, the spirit of the government has to provide full access to social services to the population at a free cost with no user fees. But look, the system was not working very well. Care are supposed to be free, but are never available because the government rarely sends the money on time, sends the consumables and the drugs on time, do not pay well the staff so that they are not motivated.
Dr. Dosu says in the 1980s, the Benin healthcare system started experimenting with user fees. If they asked the community to pay for their own care, could they deliver better care? At first, imposing user fees did make things better. Hospitals and doctors were able to get the supplies and drugs they needed to treat patients. But inequities, of course, followed, because this change only helped patients who could afford those fees.
But when you come to hospitals, the cost of services in hospitals are so high. A whole set of structures, way of thinking, way of doing, that maintain that spirit of no cash, no care. There have been temptations of introducing user fees exemptions. For instance, for HIV, for renal failure treatment, TB treatment, that are quite inherent part of the models of controlling those epidemics. And it worked quite well. But other experiences like user fee exemptions for cesarean section, user fee exemption for malaria treatment, face so much implementation challenges, mainly because of this pro-user fee culture, because key powerful players in the system hardly accept the idea that someone can come, just have services and pay nothing and run away. But in a pro-user fee culture-based system, introducing user fee exemption policies is a really challenging experience.
So now you're turning to these examples of exempting certain services from these user fees. It seems quite obvious that that's a good thing for equity, to exempt fees for everyone, particularly for low-income parts of the population for certain priority services. So that seems like a straightforward way to get equity. What have you found? Does that actually work?
The first answer is yes. Building on the example of user fee exemption for maternal health services, I have seen many women and families who accessed life-saving interventions only because they were free of charge for them. And I have seen that user fees exemption improve the morale of health staff. It reduces anxiety health workers have to face every day. The number of patients who die because they cannot afford care or who has to wait long before accessing life-saving care, that stress have been removed from the shoulders of staff when some life-saving interventions are free of charge for poor patients. And from my perspective, based on what I have observed, asking a poor woman at the end of 9 months of pregnancy to pay before delivering in a safe condition is a very violent policy. This is how I have seen user fee exemption policies saving lives, bringing smile, and preventing injustice for many millions of women and newborns.
Dr. Dosu had a huge but to my question when I asked if eliminating user fees creates more equity. Theoretically, the poorest patients are able to get care faster and more efficiently.
But if you do not put in place extra specific measures, it will happen that rich people will gain more from the user fee exemption than poor people, basically because of the existing pro-rich structures in place. So when you just say user fee exemption for all, it will happen that people living in places where infrastructures exist disproportionately in a better condition will access and gain more as compared to places where those services were not existent.
The example he gives is, what if cesarean sections were offered for free to anyone who needed one?
If you live in an area where there is no staff who can provide cesarean section, and that is frequent in rural area and high, far remote and poor area, then user fee exemption for cesarean section will not benefit to poor people living in rural area as compared to rich people living in rich area.
So how do you create a policy that helps the people who truly need the services and not just people who live where there are more resources, usually in wealthier urban settings? Dr. Dosu says there are a few ways to implement user fee exemptions. One is to offer a service for free only to the people who truly can't afford it. He says typically people think it's smarter to offer free services only to the patients with little money. But this kind of targeting can itself be complex and expensive to put into practice.
And they have good reasons and good rationale for that. For instance, why my wife, being a wife as a medical doctor, be entitled to have access to free care as a poor woman at the other side of the street. Why? This is not fair. That is one way of thinking. But when you come to implementation, it is very expensive to have a dynamic, up-to-date list of those who are poor in a community. And when you compare what it costs for you to maintain the database of poor people, you can ask yourself, okay, how many people can get additional exemption if I give that money only to everybody? The other point is usually policies that target only poor people are usually poorly founded. Why? Because to get public money for a group of the population is consistently a battlefield experience. And if you have no group of people active and powerful enough to lobby consistently to maintain the financing of that pro-poor policy up on the agenda with high political commitment, it will be an empty policy. This is why it is very complex to put in place all the necessary conditions to ensure that a user fee exemption, whether targeted or not targeted, reach an optimal level of equity objectives. But this is a very good and easiest way to go to ensure that those who are denied access to life-saving services or transformative social services to get out of poverty can access to those services of good quality so that their life can be better.
Dr. Dosu laid out some tactics they tried, like offering free C-sections, but learning there were unintended consequences. In the next episode of Pathways to Equity, we're going to talk more about the process of studying implementation to see how it is working and make adjustments. We call this implementation research, and it's crucial to making healthcare more equitable. Pathways to Equity is a production of the Health System Strengthening Accelerator, funded by USAID. You can learn more about the Accelerator's work at our website, acceleratehss.org. That is linked in our show notes. I'm your host, Nathan Blanchett. The rest of our team is Melanie Morrow, Leor Miller, Al Catron, Alexander McCall, and Nakem Wellington. This podcast was produced by Claire McInerney. It was mixed and mastered by Megan Palmer.